So we had Keynote 024, we've talked about that. I want to get back to Ed and just say, now that we've got kind of a beachhead in first line, what over the next year or so, what do you think in first line immunotherapy? Is it combining, is it other drugs are better, or do we see the other drugs as going to be similar to Pembro? Is it combinations with chemo? Is it combinations with immuno? What's on your radar screen for?
So this is my disclaimer of I'm not a predictor of future things. I don't know who's going to win the Super Bowl.
I'm from Boston, so I do.
I think I'm rooting for Atlanta, but it is obviously a very hot area and one of rampant speculation right now. I have been very impressed with the Keynote data, the 024, and the amount of magnitude of benefit in a PD-L1 overexpressed population.
Yeah.
Impressive. Just decades of stuff. That is probably the one thing that has changed a large amount of people in a paradigm. EGFR mutations were important, but it was a subset. But this is big stuff now. Yeah. And if we follow what happened with our colleagues in melanoma and renal cell, you had single agents, you had a couple single agents, and then what kind of changed the paradigm was in a fit patient who you felt could tolerate predictable grade 3 toxicities, the doublets occurred, and the doublets being CTLA-4 plus PD-L1 or PD-1 inhibition. So I think that's really an important data set that we will hopefully see over the next 6 to 12 months is what's going to happen with the combination data. That's the Ipi-Nivo. And that parallels what we would see in melanoma. Now, to David's point, maybe it doesn't show as great a magnitude of benefit. And I think there will be benefit, just again, my own sideline reporting. I just don't know how that will stack up with toxicities on top of the magnitude of efficacy.
Yeah.
And I think that's where we will be back into this debate of what is appropriate for somebody, regardless of expression, because it could absolutely have nothing to do with it. Do we take that chance to get one number of efficacy versus another? And this almost sounds like IL-2, right? IL-2 was not based on certain parameters. It was based on certain efficacies where you could get some people into a near CR or that magnitude. I think that's what we're going to be discussing because I think the numbers will come out pretty similarly and it'll be based on toxicity and whether you care more about response rate, PFS, and in those terms. And so I think that's what's going to be exciting about the next year. We do have combination chemotherapy data that was presented with pembrolizumab, with carboplatin and pemetrexed. Again, that has sort of been fast-tracked now, and maybe that will be a standard in a few months. I have no idea. I think it's still very early, but I don't know how a community oncologist now is going to resolve testing in one setting, not testing in another, and having to choose between combination chemo with a drug versus single agent. Because I think there's a big reflex to that.
I mean, it's been interesting that, for the past year, that, the posturing of the immunotherapy movement has been, we can get rid of chemo, we'll have immuno, and now with the Keynote 021 data, admittedly in non-squamous, we have the FDA stepping up and saying, well, let's take a look at this, and then we have the combo, the Tremi-Durva combo and the Nivo-Ipi kind of pulling back a little bit. And so it's kind of interesting how life comes full cycle.
And I think we're going to have 4 or 5 immunotherapies, which, as you alluded to before, wow, in the first line setting, they're all going to be tested. I don't think they'll all make approval there. I do think there is some value to the overexpression of PD-L1, and there is data out there that's really early and speculative, looking at various populations, some in PD-L1 selected, some in not. There's Atezo data that's looking at SP142, which again, you can say whether that's a good marker or not as consistent a marker. They're looking at tumor cells or tumor infiltrating cells. And again, that requires another level of sophistication. That might be some of the issues that occur with SP142. But I think right now it's too early to speculate on what's going to end up with our first line setting. There's so much being tested. I'm hopeful that we do mirror how melanoma has gone, that there are combinations. Again, there's the IDO, drugs as well. Those are very less toxic, exactly, good combinations. My melanoma colleagues tell me, yes, we love those combinations. So, those are things I look at.
Do they work? That's another issue,
right.
But at least they're well tolerated.
That's right.